So we've got, it's not too bad, is it? So you're a handsome chap, you don't have to worry about this. Right, so let's take it up a little bit. Okay, so I've got one of the plastics trainees from exprience with me today. Introduce yourself.
So I'm Miguel, one of the plastic registrar currently at exprience.
And what stage of your training are you at?
So I'd say I'm middle grade registrar at the moment.
Okay, so you joined me for my free flap on Monday. We had a chap with an anterior floor mouth resection, bilateral neck dissection, and a radial forearm free flap. Flap had been raised by our TRG fellow Daniel, and neck was done, resection done, and I began the microsurgery with an SHO on the day. We were a bit short of numbers, so we got that done, and then you kindly came in and helped with the microsurgery, which you did. So tell me about that experience.
Well, it was a lovely experience first of all.
Good.
I must admit that coming in I was a bit anxious, but I was confident given that I've done quite a bit of microsurgery.
Good.
But I found it quite useful, a few tricks that you taught me. So one, I could include the fact that you mentioned even before starting proper surgical planning. So positioning is important, and ensuring that the surgeon is comfortable. That's one of the most important things, because it's likely that you'll be there for a while. The other thing that I found at the time of doing the surgical operation was different tricks to help to ease the difficulty with microsurgery, because it can be an overwhelming thing. So one is having a very good assistant, which you were a very good assistant, and that allowed, in terms of you presenting the lumen of the vessel, particularly the artery and even the vein, which can be a bit more challenging. That made it so much easier in terms of doing the micro. The other techniques that I also learned included the fact that you presented the end of the suture to me as well. That made it easier to do the tying of the knots. Also, what I found equally important and quite supportive was the moment when you showed me how to basically rotate the needle on the needle holder in an effort to minimize the difficulty in passing the needle and changing the needle direction.
So to recap a little bit, I think I asked you at the beginning how much micro you did. You did a fair bit. Got you into the microscope, starting on the artery, and I can tell very quickly whether somebody has the hand-eye coordination, the skills to be able to complete the microsurgery. So we use a double clamp technique because it just controls the vessels, and it means I can eliminate one aspect when we're instructing trainees. You put your first stitch in. We went from a 12 o'clock position to 6 o'clock on the front, and then flip the vessels over. And as we said, there's a pretty good vessel mismatch was limited, so we could just go straight without having to compensate for that mismatch very early on. You got your first stitch in, lovely, not down all the way, no space to be seen, and the second throw, third throw, all the way down, flattening the knot, and how we can go in the opposite direction to get the knot flat without having to swap hands. Once leave one short, one long, and then I'll present the lumen as you take the stitch through, and just pick up that stitch and take it straight the way through. Just move that hand away, and that knot is through. Make sure you supinate the hand so the needle goes in at 90 degrees, doesn't damage the intima. But my job as an assistant is also to show you the intima and present that intima, present the lumen, make sure that we've got good through of the needle, back out the other end, and again put your stitches around in a circumferential way. There was a little bit of at least a 5 to 10 degree adjustment and you can do on the knot position if you find it's not quite where you want it, and you can correct for that. So we did the one side, flipped it over, did the second side. My job as an assistant is to present the lumen to you, hold that open until you get your first stitch through, and then you pick up and present the second side of the lumen to yourself and put the stitch through. But also then to dry it and to wash it with irrigant, use a Brittany or an arrowhead to dry and show that intima as well. So I think you went through that sequence really nicely, and what I liked about your technique, really good hand-eye, you stopped the needle at the right position rather than having to pull it through. That little technique of just correcting the position of the needle relationship to the needle holder by just nudging it on the background is a useful way, because you just need one hand to do that. And then when you flipped it over, stitched over, we only had one vessel, 1 point of leak. And you can sometimes get away with this. This is one thing I've been taught, is if you just wrap it with a bit of neuropathy, give it time, often it will sort itself out when those platelets kick in. But actually you went and nicely put a stitch in and corrected that. And that was the artery done. And then the next bit was the vein. We had 2 VCs joining up together, and we used a 3.5 coupler to a low down neck branch directly into the IJV. And again, the trick is to bring the mobile to the fixed. So we did the flap vein first, and then we brought that forwards to the IJV. You will always use the shorter vein to dictate the size, but try to get that as large as you can. And the other little technical tip was, when you're putting the coupler on, if you've got a really tight, big mismatch, and you're really to the limit of the stretch of that smaller vein, you want to go to the 12 o'clock position first of all to split it into half so that the stretch is divided on both sides of the coupler. That came together nicely. Nice stretch test demonstration of backflow and flow through the vein, and then that was job done. And then I think we finished with some insetting, and the key with the insetting of the anterior floor of mouth, start with the difficult bit first, which is the posterior corner. Try to attach and suture up on the buccal aspect onto the attached gingiva, and then we put these mattress sutures around all of the teeth, because the margin extended up to the margin of the teeth as well. So really nice flap inset. The patient's doing really well. We'll start having him sipping. He's day 4 today. We've seen the flap. It's a lovely inset. And one of the other little technical tips in getting that sulcus formed in the floor of the mouth is get 2 suction drains, one drain up in between the digastrics if you can, and as the suction drain comes on, it just pulls the flap down a little bit and recreates that sulcus for you. And the radial is ideal for this kind of a reconstruction. You need a soft, pliable flap as opposed to something a little bit bulky like an MSAT. More value in a tongue or an LT, which can be too thick, unless your resection is including the whole of the floor of the mouth, including the digastrics, in which case you actually want to obturate that space with a thicker flap like an LT, but that's much more difficult to inset. So thank you again, great experience. We'll get you along to some more head and neck cases. Really appreciate your time.
Thank you.
Okay,
Good.
you're going to be famous.